In this unit, we will discuss the dangers of fad diets and their consequences to athletic performance. We will also discuss the eating disorders, anorexia nervosa, bulimia, binge eating, and emotional eating. There are many fad diets that promise quick, easy, and lasting weight loss. However, few of these are valid, and some are downright dangerous. The low-carb and high-protein diet has been popular for some years now. The long-term effect of this diet, which is extremely high in fat as well as protein, has not been determined yet. Some professionals fear this diet causes heart disease. There are also extreme diets such as the Hollywood diet, juice diet, or cabbage soup diet that promise 10 pounds lost in a weekend. The problem of these diets is the very low caloric allotment and the fact that the majority of the weight loss is from water. Ephedra was and still is a popular ergogenic aid to increase metabolism and weight loss. Side effects include hypertension, anxiety, insomnia, and in a few cases, death from cardiac arrest. The baby food jar diet replaces 2 meals using actual baby food from the jar, which ultimately decreases total calories in the day. Some others follow the fad of chewing their food and then spitting it out before they swallow. Finally, the nicotine diet encourages the individual to replace eating urges with smoking, as nicotine reduces one's appetite. The dangers of fad diets in athletes are numerous. A high-protein diet excretes calcium, increases the risk of fracture, and makes one prone to osteoporosis. The increased protein is also hard on the kidneys. Ketosis may occur when an athlete doesn't consume enough carbohydrates to metabolize fat. Ketosis causes fatigue, dizziness, irritability, and headache, which are all counterproductive to performance. Long-term effects include damage to the kidneys. Fad diets interrupt normal sleep patterns and cause insomnia. They also cause a loss of water and muscle mass, not fat, which is the goal of weight loss. High protein and low carbohydrate diets increase urination, which will make the athlete prone to dehydration if he or she does not diligently replace fluid loss. Low caloric diets decrease the athlete's stamina and alertness, which increases the risk of injury. Long-term dieting causes nutritional imbalances, which makes the individual vulnerable to minor and major illnesses. Realize that eating disorders are a medical and psychological illness that originates from family dysfunction, social problems, and environmental pressures. In the case of athletics, the need to be the right size, to make weight, and to be the best is the lure that causes many eating disorders. Eating disorders are classified in the Diagnostic and Statistical Manual of Mental Disorders based on the symptoms that they present. Anorexia nervosa and bulimia are the most familiar of the eating disorders, with binge eating and emotional eating being recently included. The bottom line of eating disorders is the desire for the individual to control some part of their life because they feel out of control in another area. Thus, they use eating and exercise and body weight as their area to control. Recent studies suggest that as many as 40% of college-age women struggle with an eating disorder. In athletics, individual sports such as gymnastics, figure skating, ballet, diving, swimming, and long-distance running have more prevalence of eating disorders than team sports. Eating disorders are not limited to women. Every 1 in 10 cases occur in men. Eating disorders develop in stages. There is a fine but solid line between eating disorders and disordered eating. An eating disorder is a serious mental illness that interferes with an athlete's normal daily activities, while disordered eating represents a temporary change in an athlete's eating behaviors. Disordered eating patterns arise if an athlete tries to make a weight goal, is under stress, or intends to change their appearance or performance by making dietary changes. As long as these patterns are short-lived and do not persist, they are considered disordered eating and not necessarily an eating disorder. So what does this look like? Initially, an individual who is already dealing with significant issues in life begins a diet. He or she feels in control of their diet plan and is pleased with the weight loss, even if they are not overweight. The dieting becomes more extreme and is often combined with exhaustive exercise and the overuse of laxatives and diuretics. In binging and purging, the athlete will associate purging the issues in life during their vomiting process. The NSCA provides this statement regarding eating disorders. Eating disorders should never be misunderstood to be purely nutritional problems. That is, problems that can be corrected by normalizing weight or food intake. They are psychological disorders. The root of eating disorders is complex and multifactorial, with the etiology of the problem linked to self-esteem, family dynamics, stress, sense of loss of control, sexual abuse, and other sources. Those with anorexia will starve themselves to lose weight and become thin. However, as they lose weight, they will still consider themselves fat even though they are emaciated. They oftentimes have unusual eating habits, such as keeping foods on their plate from touching each other, eating only a few types of foods, and not allowing the fork to touch their mouth. They rarely will eat in front of others. The diagnostic criteria for anorexia nervosa is as follows. First, refusal to maintain body weight, leading to body weight less than 85% of what is expected according to height. Second, an intense fear and anxiety of gaining weight. Third, a disturbance in the way in which one's body weight and size or shape is perceived. They look in the mirror and see fat. And finally, amenorrhea, which is a cessation of menstruation. The female triad is a serious illness with lifelong health consequences that can potentially be fatal. This includes the following. First, low energy availability and disordered eating from the anorexia. Second, amenorrhea, or the absence of menstruation. And third, osteoporosis, which is thin bones, which increase the risk of fracture. Bulimia is more prevalent than anorexia nervosa. Those with bulimia usually are healthy-looking and near recommended body weight. They enjoy food and often socialize around it. However, during a binge, they consume several thousand calories, up to 10,000 at one time, followed by deep guilt, shame, and fear of gaining weight. They purge the food by vomiting, intense exercise, laxatives, and diuretics. As an anorexia, bulimia is not just about weight management, but it is a psychological disorder and coping response for stress. Those with bulimia are emotionally insecure, rely on others, and lack self-confidence and self-esteem. Whereas anorexics do not believe their obsession to weight and food is abnormal, bulimics realize their behavior is abnormal. The diagnostic criteria for bulimia includes the following: recurrent episodes of binge eating followed by purging a minimum of 3 times per week for 3 months. They also will have a preoccupation with body shape and weight with continuous self-evaluation. Medical problems are numerous as seen in this slide and include cardiac arrhythmias, amenorrhea, and tooth erosion. Binge eating disorder is the most common of the 3 main eating disorders. As most people overeat occasionally, eating more than necessary does not mean the individual has a binge eating disorder. This disorder is characterized by uncontrollable episodes of eating excessive amounts of food in a short period of time. But unlike bulimia, binge eaters do not purge. Thus, most people with this disorder are overweight or obese. The causes of binge eating are unknown, although depression, anger, sadness, boredom, and worry can trigger an episode. The typical symptoms of binge eating disorder include the following: eating unusually large amounts of food in a very short period of time, eating until uncomfortably full, eating fast and out of control, but eating alone because of embarrassment, feeling disgusted, depressed, or guilty after eating, and not including any compensatory responses such as purging or the use of laxatives or exercise. In emotional eating, the individual consumes large quantities of food, considered comfort food, to suppress negative emotions. Such emotions include stress, anxiety, uncertainty, guilt, anger, pain, and depression. Sadness and boredom can also cause emotional eating. People eat for comfort when they are at the weakest point emotionally. Comfort foods often include caloric-dense, sweet, salty, and fatty foods such as chocolate, ice cream, or chips. Treatment of eating disorders requires an interdisciplinary approach. As the coach, instructor, or athletic trainer, you should never try to individually counsel and treat a student athlete who you suspect has an eating disorder. In other words, don't manage the situation alone. Athletic personnel involved with the student athlete experiencing eating disorders includes the coach, the athletic trainer, and athletic administration. Treatment will be provided by medical doctors, psychiatrists, psychologists, and nutritionists, and includes hospitalization for severe cases and also in and outpatient programs. Athletic competition may be terminated in cases deemed serious by a medical doctor. Once the athlete returns to competition, he or she must continue to receive ongoing counseling, as eating disorders are often chronic in nature.